So good evening. Welcome to the Baker Institute. We're sorry for starting just a little bit late, among other things. Some of us actually had different times than others of us. We want to particularly welcome those participating in the Panelist Consortium's 4th Annual Symposium on the U.S. Mexico border. This year, our focus is on public health in the U.S. Mexico border region. As the title of the panel suggests, we take it as a given that the challenges facing us in the border region on both sides of the region are shared problems, both in terms of the impact they have on our communities, which of course have some migration across the border, and in terms of the responsibility we have for trying to address those problems. It's our hope that the work of our Panelist scholars that they have produced over the past year will have an impact on the current state of public health along the U.S.-Mexico border and how those problems are dealt with in the future. 5 years ago, when the presidents of 7 universities began conversations about what collaboration might look like between our institutions, we weren't entirely sure where that might lead. We had all experienced relationships with other partners that had grown and shrunk and sometimes disappeared. I have an expression I use. I call them plate relationships, where you get together, we each have plates with the seals of our institutions, we exchange them, we put them on the shelf or in the drawer, and that's the end of the relationship. Our goal here was to try to build something lasting in which each of our institutions contributed a small but not insignificant amount of resources in order to fund what we thought was an important cross-border collaboration. We have attempted to construct, through the Panelist Consortium, a community and network of scholars whose work intersects at the border and who share a commitment to policy-oriented scholarship. So now in our 4th gathering of this kind, we're pleased to have completed another year of that effort and hope that we'll have an impact on how our 2 nations think about binational public health policy. And we hope through that collaboration to make, of course, not merely a difference in policy ultimately, but in the long term, to make a difference in the lives of the individuals who live in this region. This evening, we have 3 very distinguished public health experts to lead this forum. I'm not charged with introducing them, but we have Doctors Iman Hakim, Peter Hopez, and Abelardo Garcia Cantu all work on different components of the public health ecosystem along the U.S. border. We're grateful to have this unique set of health practitioners and leaders with us tonight, and we look forward to your insights and participation. Also with us tonight is Jill Guernsey de Zapien. I am sure I have badly mispronounced that.
It's almost perfect.
It's almost perfect. You should be a diplomat or a university president. The Associate Dean for Community Programs at the Melanita Zuckerman College of Public Health. She's graciously agreed to serve as the moderator of the panel, which means she'll help us stay on schedule, coordinate the question and answer period after the presentation, and as I said, introduce our panelists. You should also know that Jill and her 2 colleagues from the University of Arizona's College of Public Health, Cecilia Rosales and Scott Carvajal, have also served as the editors of the 7 papers developed for the symposium, and I want to really thank you for that very, very generous work. And finally, I want to thank my colleagues at the University of Monterrey Tech, the University of the Americas Puebla, and the University of Arizona. Rice is really privileged to work with these fine universities, and I especially want to recognize President Deek Assad from UDEM and President Derbez from UDLAP, who took the time and made this trip to be here with us today. So thank you all very, very much. It's now my pleasure to ask Jill to get us started.
So good evening. It's very nice to be here in Houston, coming from Tucson, Arizona. I'm hoping that it's going to rain. We never get any rain, but I know in Houston you get rain all the time, so I'm always hopeful. It's been a really productive day, I think, for all of us who have been part of the Puentes Consortium. We had the opportunity to listen to a very diverse group of papers around the public health issues in our border health region, and saw incredible collaboration that's going on binationally that I think is always inspiring and makes us realize that, you know, si se puede, we can make good things happen here in the region. I'm not going to read the bios of each of our speakers in interest of time. You should have them in the program, but I did want to just tell you a little bit about each one of them, tiny bit. And I just had the honor of meeting Dr. Jotes, and I told him that before I came, I knew he was going to be on the panel, and I talked to some of the people in our College of Public Health and said, so I'm going to be on this panel with Dr. Jotes, what can you tell me about him? And they all said, oh, he's great, he's really wonderful, he's a fantastic researcher. So I was telling him all that, and he said, could you tell that to my kids? Because that would be really helpful. So Dr. Jotes is the Baker Institute Fellow in Disease and Poverty, as well as the Dean of the National School of Tropical Medicine here at Baylor College. So he's probably a familiar face to many of you here. So he's going to be our first speaker. Our second speaker is Dean Iman Hakim, who is the Dean of our College of Public Health and is one of the world-renowned researchers on green tea in particular. I always talk to her about what tea I'm going to be drinking and the antioxidant qualities that might be in it, but she is also a fantastic leader in the area of public health and is extremely supportive to the issues of border health. And so she's going to be our second speaker, and our third speaker is going to be Dr. Abelardo Garcia, who is here in representation of the Secretaría de Salud de Nuevo León and also representing the U.S. Mexico Border Health Commission. So we're going to have our three speakers speak, and in interest of time, we won't take questions at the end of each of their talks, but so jot down your notes, and then we'll have time for questions and comments at the end. So please join me in welcoming our first speaker.
Thank you, President Lebron, Dr. I can't even do it as well as President Lebron did, Dr. Dezepian. I really appreciate the opportunity. I apologize for not speaking to you in Spanish, and I've become very self-conscious after attempting to give a lecture in Spanish with my daughter, my oldest daughter, in the audience. She's now getting her doctoral degree in New York, but at the time she was an adolescent and was interested in psychology, does a lot of work in Costa Rica. So she heard me speaking afterwards. She says, "Daddy, don't ever do that again." It's so embarrassing. So ever since then, I've been too self-conscious to speak in public in Spanish ever again. What I'm going to do is talk to you about quite a terrible problem that we're just really getting our arms around, both in Texas and in Mexico. And I want to tell you about some things that are actually counterintuitive from what we thought we would find when we came down to Houston 2 years ago to launch this new School of Tropical Medicine here at Texas Medical Center and linked now with Rice and the Baker Institute. And it has to do with these group of infections that you don't hear much about relative to things like HIV/AIDS. And it's this group of tropical infections known as the neglected tropical diseases, which is or NTDs, a term we helped coin a few years ago. And what they're highly prevalent infections that disproportionately affect the poorest people in developing countries. And they tend to be chronic, disabling conditions, often not high mortality, but high morbidity. And one of the important features that I want to emphasize and what we've written about in books and papers is we've now linked them to poverty, meaning that they not only occur in the setting of poverty, they not only disproportionately affect people living in poverty, but they actually cause poverty. And we sometimes call them the forgotten diseases among forgotten people. And the reason they cause poverty is because we can show that when people have these infections, they often have them their entire lives, not always, but in many cases, so that they make people too sick to go to work every day, so that they're actually causing the economy to falter because people are too sick to work. They actually impair intellectual and physical development in children. We can actually demonstrate that the extent to children that they're infected with NTDs, neglected tropical diseases, shows how they impair physical and intellectual development, and they actually shave IQ points off. They can actually show that they reduce intelligence, and that's an important reason, again, not only impairing worker productivity, but also impairing intellectual development of children is a major poverty-promoting feature, and then a big impact on the health of girls and women, so that these NTDs are a stealth reason why the poorest people in Mexico, but also now we realize in the United States, are unable to escape poverty. And so we wrote about these diseases beginning in 2005, and tonight, ironically, our paper, a major policy paper on version 2.0 of neglected tropical diseases, just came out an hour ago on the open access website, PLOS Neglected Tropical Diseases. So you may want to have a look at that. And I want to tell you about those features. So, and here are some of the non-intuitive parts. When we were thinking about writing about neglected tropical diseases, in version 1.0, it was heavily emphasizing sub-Saharan Africa. We were really very focused on the most devastated states in Africa, places like Democratic Republic of Congo, Central African Republic, South Sudan. But in version 2.0, based on a collaboration that we have with the Institute for Health Metrics and Evaluation at the University of Washington, Seattle, look at where these diseases are. Yes, there is an African component, particularly for diseases like schistosomiasis, but for the rest of them, they're predominantly occurring outside of sub-Saharan Africa. In fact, when we look at it a little more closely, something really counterintuitive, which comes out tonight in PLOS, but we've also written about this in Foreign Policy, is that 60 to 70% of the world's neglected tropical diseases, with a few exceptions, are actually occurring in G20 countries, group of 20 countries, so the 20 wealthiest countries. And the point is, it's occurring among the extreme poor living among the wealthy. So there, again, these forgotten people who live on less than $2 a day, and this is where we're finding a lot of the world's neglected tropical diseases. And this is the most provocative slide I'll show today, which is that this is, I think, emerging as the new face of global health. It's not your father's global health, where we talked about developed countries versus poor countries, but in fact it's the poor living among the wealthy who, at least in the case of the NTDs, and I think it's going to hold up for a lot of other adverse health conditions, are occurring among areas of extreme poverty. And I'll come back to the Western Hemisphere in a minute, but just looking at northern India or northern Australia or Nigeria and South Africa or Indonesia, this is where, or even Western China, South China, these are where we're finding the extreme poverty and the highest level of neglected tropical diseases. And it's not by coincidence. I think these NTDs are actually causing poverty in these countries, and we have some evidence to demonstrate that. So we've given it a new name. We call it blue marble health to distinguish it from the old-fashioned global health in recognition of the beautiful picture the Apollo 17 astronauts took back in 1972, saying the Earth looks just like a blue marble. So let's go specifically to Texas and Mexico, since this is what we're talking about. And this is a paper that we wrote a year or so ago with colleagues from Mexico, from the Carlos Slim Health Institute, as well as from the University of Yucatan, the Autonomous University of Yucatan, people from the NIH, and the second author is in the audience, Dr. Mary Elena Batazzi, who's an associate working with me. And raise your hand, Mary Elena, originally from Honduras. And what we found is that there are a number of diseases, neglected tropical diseases, that are common among people living in the United States and Mexico. And I want to tell you about them a little bit. But one of the other things that's counterintuitive, in addition to the fact when we talked about G20 countries, is the fact that the diseases that we're seeing shared between Mexico and Texas are not necessarily those on the border between Texas and Mexico. Instead, what we think is happening is these neglected tropical diseases have their own foci in the poorest parts of Texas and Mexico, and there's transmission in both areas. So it's not so much a matter of disease coming in across the border into the United States. It's just that what we're seeing is extreme concentrations of poverty and neglected tropical diseases in southern Mexico, places like Chiapas, Veracruz, and up in the Yucatan. And conversely, there's a big pocket of poverty in South Texas. And that's important because when I started writing about neglected tropical diseases in the United States, especially in Texas and also somewhat to the Gulf Coast, you can imagine what happens when you put things up on the internet, right? All the anti-immigrant blogs start lighting up and say, see, this is why we have to build the wall higher. And I like to point out that currently about 10% of the dogs in South Texas are affected by neglected tropical diseases. And so the dogs are not slipping in over the border from Mexico and El Salvador into the U.S. There's transmission of these diseases, and what's more, it looks as though these diseases have been here in the United States for a long time, in some cases more than 1,000 years. So it's fascinating how people try to politicize these diseases. So on the far right, it's all about it's either putting the wall higher, or I'm trying to slip in Obamacare into Texas. And even on the far left, they're just as bad. So when we had an op-ed piece in the New York Times about these diseases last year, and one of the things I learned about the New York Times is they really hate Governor Perry. They really, really don't like him, and they really wanted me to say that this is all due to Governor Perry's health care. And I said, look, these have been in the Rio Grande Valley for more than 1,000 years, and there's evidence for it. So I know he's been governor for a long time, but it hasn't been that long. So it's very, very interesting. So with that version 2.0, I want to call your attention to the pictures on the right, which is this very important global burden of disease study 2010, which we contributed the neglected tropical disease part of it. It's actually emerging as one of the really important global health documents of the 21st century. And it has to do with a study that was supported by the Gates Foundation to the Institute for Health Metrics and Evaluation at the University of Washington, where they carefully evaluate disease burden for all 291 major conditions, ranging from road traffic accidents to neglected tropical diseases to HIV/AIDS to different neoplasms, cardiovascular disease. And we help them with the NTD part of it. And the important part for today's discussion is that 3 major diseases that we never really realized how important they are until very recently have come to light as 3 of the most important neglected tropical diseases of humankind. And these are the ones that are hitting our region, hitting South Mexico, southern Mexico, and South Texas. So we've been working on hookworm and schistosomiasis for a long time. We've known about those diseases. That was where we're putting our emphasis. But the global burden of disease study is a wake-up call that we have to look at the bottom 3. And that's what I'll tell you about first. So the first one is Chagas disease. And most people think of Chagas disease, which is a cause of heart disease transmitted by kissing bugs, as exclusively a South American disease, or maybe a Central American and South American disease. We now realize that this is hitting North America extremely hard. And again, it's not transmission over the border, it's pockets of intense poverty. And I say we're just getting our arms around it because no country, neither Mexico or the United States, is doing any active surveillance for these diseases. So both countries are in extreme denial. So our estimates are between 1 and 6 million cases in Mexico and between 300,000 and 1 million cases in the United States. You might say, well, that's a pretty big confidence interval, and that's because we're just working on little snippets of data. So this is a paper that came out last month, and it's called An Unfolding Tragedy of Chagas Disease in North America. And here are some of the numbers. So up to 6 to 7 million cases in North America. This is not a rare disease. About 20 to 30% go on to develop severe heart disease. It causes terrible destruction of the heart, known as Chagas cardiomyopathy. It's a debilitating heart disease that's actually not recognized as a cause of Chagas disease by physicians here in Texas or elsewhere in the United States. So if a patient comes in with severe heart disease, no one thinks to look at Chagas disease as the underlying cause. A little better in Mexico, but not much better. It's now emerging also as an important maternal child problem. So 40,000 pregnant women in North America are infected with Trypanosoma cruzi, have Chagas disease, and about 5% of them are transmitting the infection to their babies. The sad part is we do not have effective medicines. The medicines are very toxic, they don't work well, and they're contraindicated in pregnancy. So right now, tonight, there are 40,000 women, pregnant women with Chagas disease in North America, and we have absolutely nothing to offer them. There's also huge economic costs. We worked with Bruce Lee, who was at the University of Pittsburgh, now at Johns Hopkins. He's a health economist. We estimate about $7 billion cost globally and $900 million of healthcare costs in the United States, and also lost wage earning. Again, poverty promoting. At least half of those cases are in Texas, so we're looking at a cost of $500 million to the state of Texas every year, and I guarantee you almost nobody in the state legislature in Texas has ever heard of this disease. So here's where it seems to be occurring, around up to 267,000 cases in Texas, highly endemic in the dogs in Texas. We have 3 major kissing bug vectors that are transmitting the disease, and here's where they're located. It's very much more in South Texas, but we're now working with our epidemiologists, and we have some preliminary data to suggest that there's transmission even in places like Houston. So we have the kissing bugs here in Houston. They're widespread throughout the city. We believe we're picking up a number of seropositive cases among the homeless. Now, why the homeless? Well, we don't know, but we think, and again, we know there's a link between poverty and these diseases, but we can't exactly explain why. We think the homeless are sleeping in areas that are infested with kissing bugs and therefore getting attacked. Another one that's also going to be an important one that you're going to be hearing about is from the Global Burden of Disease Study is a disease called leishmaniasis, which now has been a horrific problem in Syria with the Syrian conflict. In Syria, they call it Aleppo evil, or one-year sore, because it causes a disfiguring lesion on the face. This one's not a killer disease, but it disfigures the face. And if it disfigures the face of little girls, it's really a disaster, because these little girls, when they grow up to be young women, are rendered unmarriageable, the grounds for spousal abandonment. It's transmitted not by kissing bugs, but by sandflies. It's occurring in areas of lack of garbage collection in Syria because of the breakdown in infrastructure, more than 100,000 new cases, and a lot of ongoing transmission in the refugee camps across the border in Lebanon and in Turkey, and it's been a big problem in southern Mexico and other parts of Mexico, and now we're seeing a number of cases here in Texas. And what's really interesting, this one is not even necessarily disproportionately occurring in South Texas, although we're seeing it there. It's up in the Fort Worth area, and we're even seeing it expand up into southern Oklahoma as well. So we're just just really getting our arms around this one. Dengue is the one you're going to hear a lot about in the coming years. We're in the middle, although it hasn't gotten a lot of attention of late. New numbers suggesting we're in the middle of a horrific dengue fever pandemic. India especially is getting decimated by dengue. About 400 million cases annually, 132 million cases in India alone. The only reason it's getting any global attention right now is because it's affecting Bollywood stars in a big way. It's so widespread. So Yash Chopra, the Bollywood director, just died from dengue. And Priyanka Chopra, who we work with as a celebrity for our neglected tropical disease outreach, her acting counterpart, Ranveer Singh, I don't know what she sees in him, has gotten very sick now from dengue fever. And so this is causing a lot of attention now in India. So it's amazing what it takes to get on the radar screen. Well, guess what? We have it. I know you're having a horrific problem on the Yucatan Peninsula in southern Mexico. We've had it since 2004 in South Texas, in Brownsville and Matamoros, and we've known that since 2004, but the important point is now we're all linked, and we are been actively investigating this problem in Houston. The city of Houston, as you've probably heard during the day today, is about to soon become the third largest city in the U.S., and a lot of what's fueling it is expansion of trade from the Panama Canal. With the widening of the canal, Houston's emerging as the largest, one of the largest port cities in the United States, and that's why we set up our School of Tropical Medicine here in Houston. It aims to be like the London School or Liverpool School of Tropical Medicine, but we think we have these diseases in our backyard. And so Christy Murray, an epidemiologist with us, has just determined that Houston has emerged as the first major city in the United States with endemic dengue transmission. So this was studies done from retrospective serum samples beginning in 2003, 2004, 2005. We had a couple of deaths. Most of the people that had dengue had never traveled outside of Houston. They were occurring in predominantly the poorest areas of Houston, the 3rd Ward and 5th Ward. Why is that? Why are they occurring in the poorest areas of Houston? Anybody want to venture a guess? Water. It's a trick question. We have no idea. These neglected tropical diseases, right? But so this is something we have to actively look at, but we're seeing very seasonal outbreaks. And so I think what's happening is Houston is the tip of the iceberg. I think we're actually, all these diseases I just talked about today, I think they're all over the Gulf Coast of the United States, partly because of the extreme poverty there. I'm particularly worried about dengue because we have dengue type 2 now in Houston. There's dengue 1 in Florida. If you have 2 different serotypes of dengue, those of you who know about the pathobiology of dengue know you're at risk for the severe complication, dengue fever, dengue hemorrhagic fever, dengue shock syndrome. I think there's a real possibility that we're going to start seeing this happen on the Gulf Coast. So at least throughout the U.S. and Mexico, we need to assess the neglected disease burden. I have here in the U.S., but I really meant to say U.S. and Mexico. Mexico in particular has been in a bit of denial around the Chagas problem. There's very little active surveillance. There's no access to essential medicines. We have the same problem in the U.S. We have to determine the extent of transmission and how these diseases are being transmitted. We don't have our arms around it. We also have to implement simple and cost-effective public health solutions. We have to make medicines available. We're also trying to take this on the research end. One of the things that we did is to bring to Baylor and Rice an interesting type of organization known as a PDP. This stands for Product Development Partnerships. PDPs are nonprofit organizations that use industry practices to make things for neglected diseases, such as diagnostics, therapeutic products, microbiocides, and preventatives or vaccines. And the Bill and Melinda Gates Foundation launched 16 of these around 1999-2000. Most of them are located either in Seattle, close to the Gates Foundation, or in the Washington, D.C. area, or in Geneva, Switzerland. We're the only one located in Houston. It's called the Sabin Vaccine Institute. It's one at the top there. And the Sabin Vaccine Institute makes neglected tropical disease vaccines, and our labs are located at Texas Children's Hospital, where we're making vaccines that the drug companies can't make or won't make. And we started out making hookworm vaccines and schistosomiasis vaccines for sub-Saharan Africa and parts of Asia. But when we realized the extent of the problem here in Texas and Mexico, we decided it was important to add to that portfolio, and now we're aggressively working to develop first-generation Chagas disease and leishmaniasis vaccines. And our model very much relies on working with developing country, and I'll use that in quotations, manufacturers. In fact, there's even an association called the Developing Country Vaccine Manufacturers Network. So for our hookworm and schistosomiasis vaccine, we're actively working with Brazilian manufacturers. Now for Chagas and leishmaniasis, we're looking at trying to do this in Mexico. So and it's very nice because it gives us the opportunity to build capacity with the public sector vaccine manufacturer in Mexico, which is known as Bearmex, based in Mexico City. So on the bottom left there is all the partners that are involved, which includes WADI, the Autonomous University of Yucatan, Bearmex. We're working heavily with Sinvastav, and then this is actually being supported by the Carlos Slim Health Institute. There's a lot of interesting science that goes into this, because one of the problems that we have with Chagas disease versus our worm disease vaccines is we have to stimulate CD8 positive cells, cell-mediated immunity, and doing that with recombinant proteins is not trivial. So we have a bioengineer working with us, Michael Heffernan, to look at re-engineering these nanoparticles as a solution. So that'll just stop there. This is the New York timepiece where they really wanted me to stick it to Governor Perry, but I didn't. I held it. Just to say, I think we're at the very tip of the iceberg on this problem. We're just now beginning to realize the full extent of these neglected tropical diseases occurring predominantly among people living on less than $2 a day in the United States and Mexico. How many people live on less than $2 a day in the United States? Anybody know? Does anybody live on less than $2 a day in the United States? So the University of Michigan Center for Poverty just came out with new numbers saying there's 1.65 million families, around 3 million children, 5 million people overall that live on less than $2 a day in the United States. And which state has the most people living in poverty? Here we are. So, and this is going to be ground zero for neglected tropical diseases. And just so, as again, there is an amazing parallel between South Texas and Southern Mexico. And the bottom line for me is there's somewhat of a border issue, but it's also not a border issue. It's pervasive. Wherever you find extreme poverty, you'll find those diseases. Thank you so much.
Well, I would like to start with thanking the three presidents for being with us today and the organizing committee for a symposium that very well organized. Thank you very much. What I will do is actually I will take you from the scaring picture of all of the tropical disease. And as a dean, I will just walk you really quickly over some of the programs that we in Arizona are doing across the border. And again, being the dean, I will just take the credit for what's being doing just for supporting my faculty and believing in what they do. But most of the work is being done by many of the faculty here, by Jill, by Cecilia, by Scott, and Eyal, who, among others, are working, doing a lot of good work across the border. So we are at the Mellon Init Zuckerman College of Public Health, and instead of showing saguaro, I'm just showing you are the jewel in the desert, so kind of nice flower there. Border health is not only a priority, it's actually one of the top priority for the college and also for the Global Health Institute. In the college, we have, as a group of faculty and leadership, decided to develop a Global Health Institute in which border health is on the top priority. And we have faculty who work across the countries and across the border because they have shared the agenda, and they are also working on strengthening the infrastructure. And many of the projects and the topic, whether research or education, that we are doing in the college have been discussed or are part of what the Puentes is interested in. So I will just share with you 5 of research and some of our overarching collaboration. As you heard this morning, many of them are facilitating and done with partnership with the U.S. Mexico Border Health Commission. And you will hear later from my colleague, and Cecilia is on the border, and that's why we are actively involved with them. I will touch really quickly on a couple of them, which is the Healthy Border 2010 and 2020 agenda, as well as the Leader Across Border programs. We are also very well engaged in infectious disease and chronic disease across the border as well. So for the Healthy Border 2020, well, it is based on the Healthy Border 2010. So what is the Healthy Border 2010? Back in March 2001, the Commission Binational Strategic Agenda for Health Promotion and Disease Prevention was set, and it was based on the Healthy People 2010 as well as the Mexican health indicators. And the intent is to provide border stakeholders with framework for motivating and engaging a coordinated public health action, both at the binational, the state, and the local level. And it is composed of 21 objectives along with 11 focus areas. So the Healthy Border 2020 is in development. It is a binational, it is 5-phased and 5 years effort. And they are bringing groups from diverse groups, individual and organization together in a binational technical work group to develop this bilateral strategic plan. And the members are recommended by their respective states. So all of the 10 states have representation along with CDC member from the BRFFS and MCH, among others. So what will be the mission? The mission is based on the mission of the Commission as well, which is to provide international leadership to optimize health and quality of life along the U.S. Mexico border. It's also part of the mission is to identify opportunity for binational cooperation and collaboration, as well as making people aware of what's going on and what are the issues across the border. So the goals will be measurable. We need to measure, we're talking about enforcing policy. The only way to can enforce policy and make change if you actually show data, what it is and how it's safe and what will be the benefit. It should be binationally relevant. And also it is developed with key regional partners with the help and the hope that it will change policy and help implementation of intervention that are evidence-based as well as has impact on the social determinant of health. So for the leaders across border, it is funded by the U.S. Mexico Border Commission, and it is a collaborative leadership program. So as you can see, it is a collaboration between the Commission, the University of Arizona Mellon E. Zuckerman College of Public Health, the Binational Office of Baja California, Tecnológico de Monterrey, Secretaría de Salud at the federal level, as well as the Arizona Department of Health Services. And the goal, as all of the goals that will always happen related to public health, is improving the health and well-being of the community. And it has set 3 objectives: strengthening the public health leadership capacity, addressing transborder health concern, and also develop a dynamic network of public health professionals in the U.S.-Mexico border region. So far they have 3 cohorts. They were 52 participants have completed this leadership institute since 2010. There is equal number from each of the borders, so exactly for each cohort there will be the same number from the U.S. border part as well as the Mexican part. They came from all of the 10 U.S.-Mexico border states. And the funding for 2014 is for a new cohort for 16 participants. As for infectious disease, you have heard about TB this morning, tuberculosis, and we just heard about dengue. And dengue, it is kind of known, it is a gradient of dengue transmission along the Arizona-Sonora border region. And the main issue is that in areas where there is dengue, there is some, where the dengue is available, some develop the disease and some not. And even with cities wherein there is dengue, there is some neighborhood that might develop the disease and one not. So our faculty got an NIH 4-year grant in 2012 for dengue prevention. And the main target is to identify what are the factors that lead to developing the disease in one area versus not, and what are the barriers to actually develop the disease. And the overall goal will be to develop effective control measure that can benefit both sides. And it has a very huge component of community engagement to get them aware about dengue and dengue prevention. And the partner with the University of Arizona are the El Colegio de Sonora, the Universidad de Sonora, the Office of Border Health, and the Secretariat de Salud in Sonora. As far as chronic diseases, and that's one of our maybe niche areas as well, and we have Scott Garvahal with us, who is the director and the PI of the Arizona Prevention Research Center. It is one of 37 centers funded nationally by the CDC, and it goes a cycle of every 5 years, and we have had it for 3 cycles, going for the 4th. And it fosters collaboration between academics, community, and public health partners. And the focus, as usual, is about health promotion, disease prevention, and forcing policy change, and with optimal health and well-being in the diverse community of the U.S. Mexico border region. So I will share with you really quickly how the big cycle that went during these 3 stages. And stage 1 was Pasos Adelante, which was at the border, and then stage 2, the Meta Salud, which was in Sonora, and then stage 3, returning to Arizona and beyond. So it's kind of a full good circle of working across the border. So what is Pasos Adelante, or steps forward? It's actually a 12-week educational intervention program that is facilitated by the community health worker in the Arizona border region, which started in the year of 2000. It was adapted, the curriculum was adapted based on the National Heart and Lung Blood Institute program, Your Heart, Your Life. And this program was targeted Latinos, chronic disease prevention, specifically diabetes and cardiovascular disease, with an emphasis on increasing physical activity and improving nutrition. But what the program added as well is they expanded the curriculum to include additional information about diabetes, community advocacy, emotional mental health, and how to organize working group. And basically, the community health worker organized working group, and they would lead the working group, and then before the end of the 12-week, they will stop working with the group, but ask them, encourage them to continue working with the target that after the program 12 weeks end, that the community will build the habit to work together and continue the exercise. So what was the outcome? And the outcome is actually published, and I give you the link. So by 2008, more than 1,000 people along the Arizona-Sonora border participated in this program. There was a significant sustained improvement in body mass index, in blood pressure, total cholesterol, glucose level, and health-related quality of life and depression. So Pasos Adelante has been recognized by the CDC as an evidence-based intervention addressing the CDC winnable battle for nutrition, physical activity, and obesity. And because of this success that we get funded for the other cycle. And some of the evaluation also has been done between the participant, and it has shown a very rewarding results. So what is the Meta Salud, or the goal in health, which is stage 2? The center, our Arizona Prevention Center, in collaboration and partnership with the Center for Health Promotion in Northern Mexico and the Colegio de Sonora, started the program, which is again a community intervention program based with community health workers that they both targeted primary prevention of non-communicable disease, along with specific material relevant to the population in northern Mexico, was adapted from Arizona to the northern Mexico with a more overall general guideline for healthy lifestyle. It was done in collaboration with the Secretariat de Salud in Sonora, the Colegio de Sonora at the University of Arizona, and this has been implemented and evaluated with participants in El Museo Sonora with similar successful results. So what is returning to Arizona and beyond? Well, now as it was developed in the border, it was implemented in northern Sonora, now it is on the third stage, is basically going back to serve a recently arrived immigrant and immigrant in Arizona. It is facilitated again through the U.S. Mexico Border Health Commission, which allowed the University of Arizona and the Prevention Center to partner with Ventanilla de Salud program, which is a program that it is the first step for any immigrant or going to the consulate for any health-related service or advice. And the partnership will convince the group will adopt and implement the intervention. The good thing is this program is housed in 50 of the Mexico consulates throughout the USA, and the result we are expecting to be on the same success route. And what I didn't put on the slide, and I would like to share with you that our interest and is not only focused on the faculty, because if we really you don't foster the importance of the region and the work on the region and what's going on among the students, we are not creating the new generation. So we have, in part of our service learning training for all of our students at the graduate level, so we have a border health service learning that they actually do and cross the border and be entrenched. We had it at the Arizona-Mexico border. We are now having at the Guatemala-Mexico border. And the student who went through this experience, their feedback, it is changing, it is kind of a life-changing experience. What Cecilia and Jill did, actually, they start taking new faculty coming to the college. For these, some of them are basic scientists and work in immunology. They are into the healthy behavior. And just hearing from them coming back, that was kind of a life, again, transforming. Some of them coming out of state. We recruit faculty from all over the United States, and many of them, they just told me personally how this was really a life-changing experience for them. So as national all know that national border become increasingly porous, so public health experts need to explore new ways for managing the national health system. So binational collaboration will allow all of us to build on our collective experience as we work together to improve the health and well-being of our community in the border region. And a meeting like this, when I came, I didn't know what to expect, but actually just the networking and exactly that the collective experience and knowing, just making the connection, this is by itself a plus, as we heard before from the president, that if we just build the connection and people get connected together, we can do start the seed and make the change. We have to start somewhere and one step, and that will take us for the journey. That's why I try to be short, make it on time, and I would like to thank you very much.
Well, good evening, everybody. Thank you very much to the University of Rice University, Mr. Lebron, for inviting us to come over here to share a little bit of what we are doing on the border. Almost great part of my presentation, Dr. Iman gave it for me. So it's going to be short. Don't worry for that. First of all, where do I change this? Which one? Which one? This one?
This one, yeah.
Okay.
If
No,
not,
I'll take it over here. First of all, I'm going to show you the priorities of 3 different organizations. One of the first one is the Health Secretary of Nuevo León, priorities on the border or on their state. It's a obesity epidemic problem that we have, the healthcare for adolescents, control of infection disease, healthcare for elderly, and quality of health services. Priority uses pertaining to adolescent health. We have a great problem with adolescents over there, and the sexual and reproductive health, nutrition and physical activity, addiction, and accident prevention. Those are from the state of Nuevo León. The next one is from the Border Governors Conference. Each year we have a meeting with the Border Governors Conference, and they give us about 5 or 4 topics. The states put in the topics, and we try to solve them, not solve them, try to put the guidelines for what they are going to do the next year. And the first of it was the strength of the relationship with the United States-Mexico Border Health Commission and focus efforts on obesity prevention. And that obesity prevention, we did a summit. The United States-Mexico Border Health Commission had about 16 forums in 1 year. And then we did a summit of obesity over here in Texas last September. Programs to reduce the substance abuse, prevent addiction, and promote health living. That was New Mexico who was putting that program over there. Prevention and reduction of injuries from car accidents. That was Arizona. Explore opportunities for cross-border health services for migrants and their families. Medical tourism. Probably the word tourism is not very good for everybody, but we were saying that it was services of health trans-border for our migrants. That's Nuevo León proposed that. And then establish a framework for mutual aid support in different emergency situations with the cooperation of border states, cities, and towns. California wasn't there, so we assigned that for them. That year, they didn't went, so they had their. And the priorities of the Border Health Commission, there are a lot, and there are more than these ones. You know, obesity and chronic degenerative diseases, sexually transmitted diseases, teen pregnancy, tuberculosis, mental health and substance abuse, epidemiological emergencies, breast cancer, accident prevention, preventive health, and a strategic alliance for a health border. This, if you can see, there are a lot of similarities in the 3 organizations. And the thing that I wanted you to get to know is that there are a lot of organizations working on the same things, on the same things. So let's see a little bit of story of the United States-Mexico Border Health Commission. In 1994, the Congress passed the Congress, and they were authorizing the creation of the commission. 1997. The initial funding provided started by the Office of International Affairs. And 2000, the binational agreement signed established the commission. So we started in 2000. 2003, adopting the commission statutes, the 2004 designation as an international and public organization by the President Bush, and 2010, reaffirmation of the Joint Declaration Agreement. We're going to 2020. The mission, Iman just told you the mission. The object is 2, so I'm not going to repeat that. The principles, the leadership, the focus, the space, functions, facilitate an identification study and research. I think the research is the most important part over here. Be a catalyst for raising awareness. We have awareness all over. We have programs of BEADS and AWITS where we're trying to have awareness on the border from one side and another one. Promote sustainable partnerships for actions, trying to work for long term, not short terms. We facilitate. We don't execute. We try to facilitate to help the different public secretaries, health secretaries to work what we want them to do and what we can help them. Service information portal for the community. We have to serve for the community. We work for the community. And this is the structure of the United States Mexico Border Health Commission. It's overseen by the Office of the Global Affairs in the Department of Health and Human Services in the United States and Secretary and Minister of Health in Mexico. They have 1 commissioner that are the 2 health secretaries from each country, and 3 members per state on the United States, because you have 4 states, we have 6 states, so we have 2 members for states, 12 and 12. 1 delegate for each state, and for 1 country, 1 section manager on the United States, and in Mexico it's another position, it's a executive secretary. 4 states coordinators and 6 states coordinators. We'll have one coordinator for each state. And the structure, we have a coordinating committee that has 3 committees: a planning committee, programming committee, and budget committee. They work this way. We have the United States-Mexico Commission, and we have the coordinating committee. How do we get the comments to work? All the members, each health secretary is a member, and we have a member representing the people. And we have a delegate for each state. So in each committee, the planning, programming, and budget committee, we have 3 members, one of each state, probably one of the 3 members from Mexico, 3 members from the United States, from different states. And then the president of each committee goes to the coordinate committee too. So he's going to work on both committees. And this is going to change, the coordinating committee changes each year, the president, and these ones change each year too. So everybody knows what's happening in all the commission. That's the way we work. We work all over the border, and 3,200 kilometers. We work 100 kilometers each side of the border, 62 miles. And I think that's a good option because we have a lot of different problems on the south part of the states of Mexico. They are different from the border. They are so different, the problems that we have on the other part of the states than the ones that we have on the border. Because on the other parts of the states, the people live different, or they have different problems, that's all. But we work all over, and we work vertical, because we have projects, binational projects, that we work with our states that are in front of us. But we work horizontally too. We have projects that work regional, local, binational, and all over the border. These are the offices. We have the outreach offices on states, and each state has one office. Some states, they have one office, one coordinator, but they have 2 or 3 offices more. For example, Texas gets 4 Mexican states. It has Tamaulipas, Nuevo León, Coahuila, and Chihuahua. It's a big state over here. So, and you have more offices. That's all. But for example, in Nuevo León, we have the 18 little cities that are on those 100 kilometers. But we have the migrants. The migrants, probably the human being has been a nomad, and he's been migrant all the life, and it's going to be we're going to have migrants there. We have 6 different types of migrants. The intrastates, the ones that are from the south part of the state, they want to come over here to the United States to work. The people from the state that they want to. The interstate, all over the states, they come and pass through Nuevo León. They don't stay there, but they pass through Nuevo León. Nuevo León now has only 14 kilometers of border. That's all what we have. But we have the cities that are down of the T-dead of Tamaulipas. We get 70 kilometers, and they get 30 kilometers only. So they are really the border. The 4 regions, La Bestia, you remember that railroad that comes from south okay. In the Bestia, we have all over Central America, South America, all over they want to come. And if you see that train, I don't know if you've seen over there on the television when they pass the train, it's like those trains that are over there in India and Egypt, I don't know. They are full of people over there. They're coming with families, children. Everybody's coming over, trying to come over here to the States to have a better life. The returning immigrants, the guys that come over here, they have papers, they work, and they get back over there. And probably most of them, or many of them, they don't get treatment for their sickness over here, sometimes because they don't have papers, sometimes because they don't have the resources to go, and they get back over there with new sickness over there. The transient, or the heavy operators, the trailers, that they go all over from Mexico to New York, I don't know where, because we are passing all over to Canada too. So they are just taking their sickness all over the countries, both countries, So, and the local population, because the local population is influenced by all the people that passes through, and they stay in the conditions of assimilation. In the conditions, they don't have water, they don't have services, they don't have nothing. And they're trying to pass the border. So we have 6 different kind of immigrants over there. The actions that we programmed for 2014 is, for example, yeah, Iman just talked about that, the Face of Healthy Border Plan 2020. Leaders Across the Border. Leaders Across the Border is a very, very good program. They've been having a lot of, some of the works they've been proposing, they are implementing right now over there on the border. Healthy Border Communities Initiatives. Binational Consortium of Health Research. That's where we would like to invite, we would like to be part of all the research that you have over here. Binational Border Symposium of Resource Coordination too. We have to learn how to get resources so we can help others. Binational Border Summit and Reproductive Health. U.S. Mexico Border Tuberculosis Consortium. We had a consortium, we have doing it for more than 5 years. We have a consortium and we have a legal forum of tuberculosis. And both countries work together to see how we can get the biological things for one side and another one. How can we have programs, how do they take the patients when they're going to send them back to Mexico? They used to put them over there on the border or on the bridges at 12 o'clock in the night, and we had over there patients, we have persons from the Yale, we have children's, we have everybody, they just put it over there and say goodbye, it's 12, go to Mexico. So the tuberculosis persons or the infected persons didn't have a control when they get back to Mexico. And right now, thanks to Arizona that proposed that one attack, we have a very good program that we call it Meet and Greet. They tell us when they are going to take the persons back. We have all the organizations, the Mexican organizations, to receive all those patients, all those persons with sickness, with infection control. And then they receive the persons and they could take it. It's more order for that. We have the infectious disease conference that Iman talked about that. The Technical Binational Working Group for Obesity Prevention on the Border. This technical binational working group was born after the summit of obesity we had last year. So we are going to start with that. Initiative for Preventive Health Among Vulnerable Populations. That came about when they did the Ventanillas de Salud that we have in more than 50 Ventanillas de Salud. Windows, health windows, that's what we call, and all the consulates. And we have the Binational Border Health Week that we work all over the border. We have more than 8,000 direct actions on both sides during 1 week. It's a very good one. And the Covinas is not Combinas. The M is wrong over there. The Covinas is the Binational Health Council. We work with the people, both sides. Most of the times, the cities that are working one another, many times they have their own programs to work together. And so they are the real people that's going to tell us what's happening on the border. They work the health departments with the Secretaría de Salud on the Mexican side, and they know what they need. So we try to work with them. We just talk about this, the Border Governors Conference, what did they ask to do, and we did the job. We did it, all the states, we got together, we established what we were going to do, and all the 5 recommendations are now waiting to be received in the conference. The conference is being delayed until January for problems, I don't know if economical problems. It was going to be in Chihuahua, but right now I don't know if it's for the insecurity or something like that. They changed it until January. But here are the answers, the response for all those problems or updates that we had to do. Challenges, what challenge you? Operating along one of the busiest and most complex binational borders in the world, supporting national, state, and local public health systems. You can imagine that on the border that we have in San Diego, we have 54 million people crossing each year. We are talking about 1 million people a week. That's a lot of persons, one side and another one. assisting to promotion and prevention of health problems at the border. We have to do that. Communicating and committing to the different priorities of each government. Each government, we work in the states, but we have to work too on all over the border. Sometimes the problems that they have on California are not the ones that we have on Texas or something, New Mexico and Nuevo León. So we try to work on the same necessities of the border. Increasing partnerships with academic institutions, other government organizations, and public and private institutions. We think that if we have partnerships just to work, to be the venue to work with them, or not to duplicate the actions, because if they duplicate, everybody tries to do the same on tuberculosis, and it's only wasting the money. So we have to have promoting sustainable partnerships. That's what we want. These are the partners that we work in the United States, Mexican Minister of Health, Department of Health, Minister of Foreign Affairs, that's where the Ventanillas de Salud, Minister of Education, academic institutions, researchers, state and municipal authorities, policy makers, CDC, Instituto Nacional de Salud Pública, organizations not governmentals, PAJO, and COLEF, Colegio de la Frontera Norte. All these institutions who work with us, we try to work with them, they show us the guidelines and everything. Conclusions. It is necessary to work as a team with all the organizations present at the border so that the actions are not duplicated. I just said that. We must be inclusive, creating bonds and bridges between universities and their faculty researchers in order to support decision makers in different regions to achieve better results from our work in health promotion and prevention. Third, organize a common cause for the not governmental organizations and government authorities, federal, state, and local, to work together. And I finish just with these 6 words: forming ties and building bridges, commitment, continuity, sustainability, strengthening the consortium, and expanding the influence. Thank you very much.
Wow, that was a lot of information in a short period of time, but we have a few minutes left for questions and comments from people in the audience. Thoughts?
Dr. Otes.
Can you speak up so everyone can?
Dr. Otes, when you're going out and tracking these diseases in the more developed countries and you're finding them, do you think that you're finding them more so because of better medical ability to track them there versus in other countries that don't really pay as much attention to them, or do you think there's actually a bigger collection of people that have these diseases in these countries, or you think it's a lack of reporting?
So the question, thank you for the question. I'm often asked, are these diseases emerging in Houston? Are they new? And I don't really know the answer to that. I think in many cases they've been here a long time. It's just nobody bothered to look because they are occurring primarily among the people living in extreme poverty in Texas and especially in Houston. So this is a great concern. What's also quite interesting is after we have found these diseases, the lack of reaction, the lack of interest, and in my frustration, I often say, can you imagine if we had found dengue or Chagas disease in Brookline, Massachusetts, or Bethesda, Maryland, or in Westchester County, or in the wealthier suburbs of San Francisco or Los Angeles? This is a society we would never tolerate it, but because it's occurring among the poor, it's somehow not really, it really hasn't generated as much national interest. So when we write about these diseases, we get blips of interest like the New York Times or something on CNN, but it doesn't generate critical mass, to use the atomic metaphor. It doesn't catch on and really ignite a tremendous amount of interest. So the sociology is interesting. I can get more interest about neglected tropical diseases in Zambia or Zimbabwe than I can right here at home.
Thank you.
A few of you mentioned migrant and immigrant workers, and I'm wondering if there's any particular diseases that those populations might have in terms of communicable versus non-communicable diseases, or if there's certain treatment or tracking of that population.
Me?
Of many, yeah.
Well, the problem with those populations is that many of them come without papers in Mexico. That's the reason that we are not tracking sometimes them. The problem that our south border is that many of that people, those persons come without papers. We don't know. They have the right to have health, but if I don't know who came in, how can I help them? So we're trying to talk with the consulars or something. We have to know who comes in. When they come and they pass through Mexico, I think that the infectious diseases are the ones, the biggest one. But they have a lot of problems on all the way to come to the border. They have abusing of them. They do a lot of things, you know. They change. Sometimes the train can make 1 day or 2 days, but they make 20 days or 30 days to get to the border, and then there are conditions that are not human conditions. So many times we don't have the way. When they come back, we try to track them. Yes, that's the reason that we try to put order on the way that they send us back those persons, because the other way. The problem, for example, the tuberculosis, the person that has tuberculosis treatment over here, and they are sending it back, he doesn't want to tell us over there that he has tuberculosis because he won't have anywhere to work. He doesn't want that his family knows that he's with tuberculosis, because their children probably will have problems. And that's the reason that they try to go without telling us they have tuberculosis. We try to track them. Yes, we try to.
Yeah.
I'd like to hear your thoughts. I would think that many of these conditions, I think as Dr. Hotez is stating, really originate in varying degrees of poverty and with poverty. And I'd like to posit that really, you know, I think as we've been discussing through the Puentes Consortium, these are issues of migration, but not always of migration. They're issues of structuralism and of infrastructure, or thinking back to social economic resources. And so they're problems they become health issues. But essentially, if we think, let's say, about why someone might migrate from Chiapas all the way to Texas or Arizona, you know, it's because they don't have opportunity. So I want to hear your thoughts. I mean, this is a much broader discussion, right? But it's around educational opportunity, it's around economic opportunity, and what I'm hearing, even with the Board of Health Commission, I'm hearing the downstream effects of bigger policies or inequalities. But at what level can we engage governments or around these grosser inequalities that end up fueling these
Well,
issues?
in Mexico, the United States, the Commission works through we facilitate and work through the Health Secretary. We don't execute. We don't do nothing. We just facilitate them. We try to help them in which problems we can promote the health, the promotion of health, making all the campaigns they want to do, the Border Health Week, but we don't ask for money. We try to help the health secretary. They have the same programs almost. That was the reason of the first 3 or 4 slides. We work on the same programs. We work on the same topics almost. So it's just to reinforce what they are doing or try to help them to do things. Many times they don't receive on the States all the needs that they should put to work, because sometimes they don't come back, or they distribute and they don't get to the state or where they need it to be working. That's the reason we have to work with other organizations and trying to all of us make a pool over there so we can do. That's all. But we work with them. We don't have to ask for money to work with them.
I agree with that completely. I would just also add that the old biomedical model doesn't work for health. We need an unprecedented dialogue with economists, with political scientists, with sociologists. We need the historical context. That's why we need a Baker Institute at Rice University to bring people with diverse views together, because we call them neglected tropical diseases. They're diseases of poverty. And I think the other important component is the girls and women's issue, that these are hitting girls and women particularly hard. And we don't know exactly, when you intuitively you understand it, but when you actually try to write down mechanisms, what is it about poverty, why girls and women, it becomes a much harder thing to do. So it lacks rigor in trying to understand what the basis is.
Mike.
The numbers you present on the NTDs are stunning, really. What I don't understand is the scale of that problem in terms of numbers when you look at drug development models. Is it large enough to get the attention of the drug developers, or are these essentially orphan diseases, particularly compounded by the fact that you're dealing with audiences that may not be able to buy the medication to get the development paid for?
Yeah, I mean, the pharmaceutical companies traditionally have shied away from neglected tropical diseases. It's not that they're bad guys. They've been donating medicines that we use in packages for sub-Saharan Africa and elsewhere, but getting them to invest in the R&D has been a heavier lift. The idea that neglected tropical diseases occur in the U.S., does that create a new niche, a new market that might persuade some of the pharmaceutical companies to go into it? It's unclear, because yes, they're in the U.S., but it's not occurring necessarily among the middle class or the upper class. It's still the poorest of the poor. So that remains uncertain. The pharmaceutical companies have gone into dengue now, so each of the 5 major pharmaceutical companies are trying to make a dengue vaccine. There are a lot of technical hurdles, so they see something there, and whether it's a U.S. market or whether it's because now you have dengue in Singapore and Rio de Janeiro, and some people say the whole World Cup games in Brazil are going to be disrupted by dengue. This is maybe generating some interest.
Yes, I'm wondering, there are at least a couple of times the idea of the ventanillas de salud came up, and I think that's interesting, but also we know from migration literature that a lot of migrants actually do not get close to consulates because they don't see them as very hospitable, etc., etc. So are there other mechanisms, for instance, more community-oriented ventanillas de salud, or I don't know, that sort of fills in this gap in terms of reaching migrants, especially people without papers, to get access to health services in the U.S.?
Well, in the U.S., I really don't know how
Well, it's Mexican consulates in the U.S. that
no, the Mexicans, yes, but they only have orientations. We have 52 ventanillas de salud.
Yeah.
In Alaska, we have one.
But I mean, the question is, do they actually reach?
I think Dr. Rosales can shed some light on the U.S. part.
If I may, the ventanillas, yes, are housed within the consulates. There are 52.
Yeah.
But there are other
Organizations
mechanisms that they use, such as mobile units that go into areas that have clusters of migrants.
Okay.
You also have nonprofit organizations that serve as fiscal agents for some of these ventanillas. And so they do outreach into these areas where they know there are clusters of migrants, and so they actually are not just coming into the consulate offices, but they're also community-based organizations that are working with this
That's
population.
what
They go out with trailers and they put over their homes, and they get people. They go to the countries and they get the people, the migrants, so they can go fast and easy to the Ventanilla Salud. They have a mobile Ventanilla Salud, some of them. So they go where their farmers are working on those parts so they can get orientation there.
I think we had a couple more questions. So actually, you had a question, and then someone towards the back. Yeah. So first down here with the turquoise one.
Okay. Hi. So I guess, do you think that maybe, which is the biggest contributing factor to the fact that these are concentrated in areas of poverty? Is it more the lack of access to preventative medical treatment, or is it more the conditions in which they live?
Well, so it's a question we're asking every day, and we're just beginning to get our arms around it. Clearly, poor quality housing is a major factor. Lack of, especially with some of the vector-borne diseases, lack of air conditioning, lack of window screens, lack of windows. That's an important part. Living in environmentally degraded areas, lack of garbage collection, which allow the vectors to breed. I think these are some key features. Lack of access to health care. Although one of the things we're finding is people are asking me, well, is Obamacare going to improve things? Well, the Affordable Care Act. The problem is these people are 2 degrees of separation away from even entering the system, and what's more, the physicians and nurses aren't even trained to think about these diseases. So we aspire to get to that point, but there's no active surveillance being done by these diseases. So we've got a problem in the U.S. in that there's a heavy emphasis on imaginary diseases. We invest in H5N1 avian flu. We invest in smallpox and anthrax, what I affectionately call the imaginary illnesses that scare white people, and there's 0 cases of these. And here we're finding neglected tropical diseases are widespread, but they're occurring among the poor people and mostly people of color. And so we've got to figure out a balance there that we haven't figured out yet.
As a prospective healthcare provider in one of these endemic areas, specifically with pediatric and adolescent populations, what can the role of the healthcare provider be in not only recognizing and treating these neglected tropical diseases, but in attempting to prevent the occurrence of them?
Well, I'll just say briefly, I didn't pay him $20 to ask that question. We have created a new diploma in tropical medicine. It's an 8-week diploma course to educate physicians and healthcare providers about these diseases. It's a very concentrated course. I mean, there are other ways to do this as well, but that's one way. So we're trying to provide training opportunities because there aren't a lot of training opportunities in these, and a lot of these diseases aren't even taught in medical schools. In some cases, not even taught in public health schools.
One final question.
I'm sure Arizona has been recognizing this for a while and doing the same.
In Arizona, because of the rise of and the concern with infectious disease, we are actually building a quorum of faculty in infectious disease. We started 5 years ago with one, and the one was running the malaria and the dengue, and all of now we are, how many? We have 5 or 6. They are focused, so they are now trying to cover different aspects, maybe not Chagas. I was talking with one with leishmaniasis, but also even like valley fever and stuff that we have also within Arizona.
And you have Aedes aegypti mosquitoes in Tucson now, so that's
yeah.
very
So we do the study across border for dengue. Yeah, and even in Florida, our faculty were engaged in this publication that just came.
Yeah. I think you were back.
Certainly. I wanted to bring up now the issue of the non-communicable diseases like obesity and diabetes, and how this is such an economic issue also, in the sense that the poor will get their calories where they're cheapest, and that's usually the worst foods. And I commend Mexico for what it's doing as far as trying to make those bad calories more expensive. I think the new taxes they're putting on those. On the other hand, though, what does that do to the poor? That where will they get their calories? Now, is there a system to get them the healthy calories?
Well, the problem over there in Mexico, they are thinking that the taxes they're going to be applied over there, but I don't think they're going to still buy the sodas and everything, because their calorie supplements sometimes they are so poor that they take a Coke in the morning and they have a bread with 1 chile of jalapeno to work. And that's their meal for all morning, all day, sometimes in the middle of the day. And they're not going to quit of the Coca-Cola because the water is not going to provide the energy they need. Some of them, the ones that work, they're not obese. That's the way they live. But the people that's poor and they are obese, it's because they eat whatever they found. That's just culture, and that's a big problem that we have over there. Our culture, poor people, they don't know what to, they think that they can eat everything they want. The real poverty kids, those are the problems, because they eat whatever they give them, but that's what they can have. They can have meat, they can have fish, they can have nothing else. So that's a big problem. They live in poverty. We have to recognize that, and we have to try to help them to change. It's a big problem.
From our perspective, one of the main meal that the kids get is the school lunches, and many of our faculty, among others, have been very active with many of the school districts to change their cafeteria food, because many of the underserved kids will eat mainly either meal free or subsidized or very subsidized. So there is a lot of activity and a lot of, even on the adult side, working with their machine, like automatic machine, to try to get the soda out. And as a level of the college, we understand, and among it's kind of a national, that obesity is the next tobacco epidemic or pandemic within the U.S. And we actually at the college came together along with the College of Medicine, the nutrition department, along with the diabetes center. And we were having a whole place within the health department, which is kind of public health, and target the metabolic disease all the way from young to up, including education, physical activity. And part of our mission at the college, we developed kids camp for underserved, completely free. We raise money for it. When the kids at age of 6 to 9, they come and learn about physical activity and cooking and exactly how to substitute the meal. And the parents, and we have even Cecilia coupled, that the parent actually attest to how this make a big difference, and the kids are showing them. And so it's working, and you need to work really young age. So I'm seeing that's a coming epidemic, and we are tackling very heavily.
Okay, we do have one final question that I promised him. So.
Peter, Norman Borlaug was known for the Green Revolution and increasing crop yields. Before he died, he was very worried, not about neglected tropical diseases, but all tropical diseases were increasing rapidly. And he said one of the reasons is we had outlawed DDT. He could find no scientific evidence that DDT hurt humans. It would reduce the size of the thickness of a bird eggshell. And before he died, he said there was an effort to bring back DDT for vector control. And he said, like in Ceylon, malaria had been basically wiped out. And when you eliminated DDT, there were at least 100,000 cases. Has DDT been brought back as vector control?
It's not been brought back widely. It's been brought back in pockets. It's going to be very interesting to see what happens if we start seeing a lot of dengue fever on the Gulf Coast, whether that could drive the reemergence of using DDT. We also have the problem that DDT resistance can develop pretty easily. That's one of the things that thwarted malaria eradication efforts. So it's going to be we're in for interesting times, as they say, because we've got Aedes aegypti widespread now among the Gulf Coast. We know there's dengue now. Chikungunya is going to probably happen in the Gulf Coast, I think. And I have a piece coming out in PLOS in a few weeks saying, could yellow fever return to the United States? So that's all going to get very interesting.
Well, we definitely had a very distinguished panel and some really provocative discussion. Please join me in thanking our panel.